for. It just reminds you that structured cases have a somewhat standardized format. You will often be presented with a clinical problem, generally brief, although not always. And you'll often be asked about differential diagnoses. How would you evaluate a problem? Remember, whenever you're evaluating, think about the pertinent positives in the history, the physical exam, and then labs and testing that you might consider ordering. And management always comes into play. Sometimes you'll have a follow-up question, or as we do in a lot of our webinars, you may have a question that leads off the scenario, and that also may happen in the real exam. All right, so with that said, tonight we're going to do some general topics review, OB, GYN, and office practice. I'm going to go ahead and get our first candidate into the hot seat. Dr. Todd, is it okay if I bring you into the hot seat for the first case?
Yes. Can you hear me?
Yes, I can.
Okay.
All right, so here we go. What is your differential diagnosis for vaginal discharge?
So my differential diagnosis includes sexually transmitted infections such as gonorrhea, chlamydia, trichomonas, bacterial vaginosis, yeast infections, some type of abscess, either in the vagina, cervical. You could have pelvic inflammatory disease. What I'm thinking right now.
Okay, good. It's a very nice list. I would add, because this is just a general question, I would add atrophic vaginitis, which might, in some cases, result in discharge. It's also possible that a patient might have a vulvar problem that actually presents with a complaint of vaginal discharge, but is coming from a vulvar issue, perhaps like HSV or some other ulcerative lesion of the vulva. All right, let's go to the next slide. So a 23-year-old presents with vaginal discharge. The first question, is it necessary to do an examination prior to treatment? What tests would you do to evaluate her?
Yes, I feel it is necessary to do an examination prior to treatment to evaluate where is the discharge coming from, what does it look like. Again, we talked about it could be vulvar or vaginal, so I think it's important to take a look and make sure, and then that would be able to lead to testing. You have to do an examination to do some of the testing. And tests that I would do to evaluate, I usually start off with a pregnancy test because that can help me rule out certain treatments that I may or may not be able to do. And then my lab has a vaginitis swab, which is a PCR for gonorrhea, chlamydia, trichomonas, bacterial vaginosis, which includes Gardnerella, and then the different Candida swabs.
Okay, and I suspect that most of us are doing one of these swabs that looks at DNA testing for vaginitis. I'm going to ask you, can you tell me regarding BV, the Amsel's criteria?
Yes, so Amsel's criteria is greater than 20% clue cells present on wet prep examination. It is a elevated vaginal pH, a vaginal discharge that's present, and I believe there's one more that I can't think of right now.
Okay, and the one more would be a positive whiff test.
Okay. Mm-hmm.
Okay, all right. Let's go to the next slide. Discuss treatment for BV, Candida, and Trichomonas.
So for BV and Trichomonas, I use an antibiotic. Candida, I would use a antifungal treatment, either oral or a topical.
Okay, can you give me an example of one treatment regimen for each of these?
So for bacterial vaginosis, I do metronidazole, 500 milligrams twice a day for 7 days. Trichomonas, I do the same, metronidazole, 500 milligrams twice a day for 7 days. And for Candida, I usually do, if they're not pregnant, diflucan 150 one time And if they are pregnant, I use a miconazole cream.
Okay, a couple of follow-up questions. So for BV, would you consider metronidazole gel to be an alternative?
Yes.
Would you consider metronidazole gel to be an alternative for trichomonas?
No.
And for treatment of candida with fluconazole, what would you expect the cure rate to be with a single dose of fluconazole?
I don't know of an exact cure rate with a single dose, but I would suspect it's high.
Okay, does high mean greater than 50%, greater than 75%, greater than 90%?
I would say greater than 75%.
Okay. So just to give a little bit of feedback on these answers, I think that the important point is that these are common enough of conditions that we encounter that the examiners would be surprised if we couldn't offer one appropriate treatment regimen for each of these three. These are the three most common causes of vaginitis. For BV, metronidazole, 500 milligrams, PO twice a day for 7 days, like you said, also an effective treatment for trichomonas. Metronidazole gel is a reasonable choice for BV, but not effective for trichomonas. So it would not be an acceptable second line choice there. For Candida, fluconazole, 150 milligram times 1. This would have an 80 to 90% cure rate. Fluconazole is actually present for about 72 hours following administration of a single dose. So even though it's only a single dose, it does have an extended period of time during which it is effective. I will just mention that BV, you could also use clindamycin vaginal cream. And for trichomonas, another common therapy would be either tinidazole or secnidazole. Both of those treatments have the advantage of being a single dose treatment, but they are limited to non-pregnant patients. So again, Dr. Todd, I appreciate you taking this first case. I think you did a very nice job. And this is the last slide. Questions for me before I let you out of the hot seat?
I just thought about, is it okay to kind of keep it vague with antibiotic, like I said, antibiotics, BV or trichomonas to kind of help further the conversation, or would that seem too vague for them?
No, I thought that was great because your answers were completely reasonable. I didn't ask you for specific dosing regimens, but of course you knew I was probably going to come back and ask you that. So I thought that was well played. I think that the way you handled it would not be problematic in the exam. Okay?
Okay, thank you.
Yeah, you're welcome. I'm going to mute you there and I'm going to bring our next person. Just let me get to the list here. Dr. Batista, can I come to you next?
Hello?
Hello. Okay, if I come to you next?
Yes.
All right, the second question for the night. Why is annual influenza vaccination important? So specifically, the key word here is annual. Why is it important to do it annually?
Um, the reason it's important to do a flu vaccine annually is because the flu virus mutates, or the most common version of the flu virus changes each year. So the vaccine changes to treat the most common type of or version of the flu virus.
Okay, and a second question for you. Why is it so important that we get our pregnant patients to be immunized against influenza?
Pregnant patients are at higher risk of complications from flu, such as like hospitalization, respiratory problems, intubations, increased risk of death.
Fantastic. Both of your answers are, excuse me, completely appropriate. This may seem to some of you like a basic topic. It is a very, very important topic from the standpoint of population-based health measures. We can really, really impact trends in illness and morbidity and mortality by making sure that we get our patients vaccinated for influenza. So let me go to the next slide. So this is a true-false question. I don't know how often something like this will come up in the exam, but they can certainly ask it in a different way. So here's the question, Dr. Bautista, that you're being presented with. Studies have shown that when the recommendation for and the availability of flu vaccination come directly from a woman's obstetric provider, there is a 5 to 50-fold higher rate of vaccination. Do you think that this is possibly true, or do you think this is probably false?
True.
And you would be correct. When an obstetric provider recommends and can provide the flu vaccine, the likelihood of a patient accepting it and getting vaccinated is much higher. So we have a really important role to play here. All right, going to the next slide. A 24-year-old G1P0 is pregnant during flu season. Discuss your counseling regarding the influenza vaccine. So that's the first thing I want you to do, and then we'll hit these questions. So what would you tell the patient regarding influenza vaccination?
I would counsel that that I do recommend to all pregnant women to get the flu vaccine to help lower risk of complications, and it would be safe in pregnancy.
Excellent. The two things there, it's a strong recommendation to get the vaccine. And the second part is, all of our pregnant patients are thinking in the back of their mind, is this going to be safe for my baby? And I think it's important that we get that out there. Okay, so the first question, what does it protect against? Another way this question could be asked is how many strains of influenza and what type of influenza are in the vaccine?
I would have to look that up. I don't know.
Okay, well, take this question. How many strains? How many strains of influenza do you think are in the vaccine? Give me an educated guess.
At least one.
Okay, at least one. That's a very good educated guess. Are you familiar with the different subtypes of influenza? When you do a rapid flu test, it may actually differentiate between influenza X and influenza Y. What are those subtypes?
Oh, I believe A and B.
Excellent. So this is an important point for working from what you do know to what you don't know. If you would say influenza A and influenza B, you would be correct. If you were to say 4 strains, 2 influenza A and 2 influenza B, you'd be spot on perfect. Okay? But you knew A and B, didn't you?
Yeah, yes.
Yeah, okay, perfect. All right, I like it. So the flu vaccine is quadrivalent. All the flu vaccines that are available today have 4 strains, 2 influenza A, 2 influenza B. Each year they select the most suspected high probability strains to put into the vaccine. And so that's really what you need to know about that. The next question, who should be vaccinated?
Everyone should be vaccinated.
Okay, would you vaccinate a newborn in the nursery?
Oh, I would vaccinate people 6 months and older.
Okay, perfect. So again, when you get a question like this, who should be vaccinated? Think about the basic underlying issue. They're really asking about an age range, and then if you wanted to talk about contraindications, you could, but it's going to be anybody 6 months and older. How is the flu vaccine administered?
There are 2 types. There would be the injection, intramuscular, and then the intranasal vaccine.
Can a pregnant patient receive either?
A pregnant patient can get the intramuscular or the intramuscular vaccine, but not the intranasal vaccine.
Perfect. When is influenza season?
It starts in September and ends in the spring.
Okay, now I'm going to tell you that you can look this up in different places. You'll get different answers. According to ACOG, influenza season is October to May. According to Up to Date, influenza season is November to April. And according to Dr. Batista, it starts in September and ends in the spring, which is perfectly fine. Remember, when we talk about October to May, we're talking about the Northern Hemisphere. I think the key is that it's really the winter months. You will notice if you look at if you give flu vaccine in your office, if you look at the expiration date on the vaccine, it's usually a June expiration date. So you can give the flu vaccine even late into the spring. Of course, the peak of flu season is usually around January, February. So you're better if you can give it earlier. Already it's available and should be being administered for this year now. So, okay. We already talked about how often should it be given, and what was the answer to that?
Annually.
Perfect. I'm going to ask you one. I agree, annually. I'm going to ask you one more question that's not on here. So if you have a patient who is 65 or older, will she get the same vaccine that you give to your 20-year-old pregnant patient?
For those older patients, they should get, I believe, the quadrivalent flu vaccine.
They're all quadrivalent, so I would agree with you.
Oh, it's like a higher dose flu vaccine. I forgot how they phrase it, but there's
Perfect
like
answer. High dose is fine. You can say the high dose flu vaccine. You can say the senior flu vaccine. Both of those are generally equated to mean the same thing. The bottom line, why does a patient 65 and older get a higher dose vaccine?
because of their weaker immune system and their higher susceptibility to complications from the flu.
Perfect. Their immune system is less responsive, therefore they get a higher dose flu vaccine. They are, of course, at higher risk for complications of the flu, so we want to make sure they get an appropriate immunogenic response. Very nicely done. I'm going to let you out of the hot seat unless you have any questions for me before I do.
No, thank you.
Okay, good job. I'm going to go back to my list here. Dr. McDowell, can I come to you next?
Yes, you can.
All right, I'm going to give you the next question. What is the difference between selective reduction and multifetal pregnancy reduction?
So my understanding of selective reduction includes where they, in a multifetal gestation, they would terminate one fetus, typically based on the safety profile of being able to do that, like the fetus is closer to the abdominal wall. Whereas with multifetal pregnancy reduction, they would be selecting for multiple fetuses to be reduced.
Okay, so good answer, but let me just mention there's one slight issue. So with selective reduction, the fetus fetuses that are being chosen for reduction are based on a health status issue.
Okay.
So we're selectively reducing based upon some concern regarding that fetus's health status. In multifetal pregnancy reduction, it's like you talked about, the fetus or fetuses to be reduced are chosen based on technical considerations, such as which is most acceptable to intervention. Now, I want to point something out about this question. This is a question that crosses some moral thresholds for certain people, okay? One of the things that we run into in the practice of obstetrics and gynecology is that we have the intersection of personal moral values and of medical practice. And so you may be asked a question like this in the exam, And answering the question has nothing to do with your own personal moral feelings. And I think this is really important because sometimes people get into the exam and they may be caught off guard by certain questions. But the key is always focus on what is the medical treatment issue. And in this case, whether you agree or disagree with this type of treatment, it's really, there's a fundamental difference between these two techniques. And it gets down to whether the selection is based on health status or based on just the ease and accessibility of that particular fetus. All right, I'm going to take you to the next slide.
Okay.
36-year-old presents to you for treatment of primary infertility. First question, what is the incidence of twins and higher order multiple births? And the second question, what are the risks associated with multifetal pregnancies?
So I know the incidence of twins is increasing with the use of reproductive technologies. The exact number I don't know for sure, but certainly those numbers are increasing. And the risks associated with multifetal pregnancies are associated both with maternal and fetal risks. For maternal, there's an increased risk for developing issues with high blood pressure, diabetes, needing, going into preterm labor and resulting in preterm delivery. There is a risk to the fetuses of spontaneous abortion, stillbirth. There's a risk of being born prematurely and having growth abnormalities as well.
Okay. I like the strategy you used thinking about the fetal or infant risks versus maternal risks. And I'm a big proponent in the exam of always trying to build in strategy to your answers wherever you can, strategy or structure that helps you remember multiple things without having to memorize a list. And I think if you're thinking about infant versus maternal, it helps you generate things that you could say. So I will just mention on the maternal side, I would also include postpartum hemorrhage. Okay.
Okay. Mm-hmm.
On the fetal side, there are a number of things that are kind of associated with prematurity, cerebral palsy, learning disabilities, chronic lung disease, developmental delay. All these things potentially increased with multifetal gestation. Now, I want to go back to the first question. You told me that you thought the incidence of twins was increased. I didn't hear you specifically comment on higher order multiple births. Higher order would be triplets or above. Was that intentional?
Right. I think I probably just forgot about it, to be honest. I guess I would say for higher order multiple births, I think that those would be lower since especially for reproductive technologies, that they are more so going towards single embryo transfers rather than multi. But again, I don't know the exact number.
So I want to ask you this. Do you think this is a hard question if they ask you specifically for the incidence of twins or higher order multiples?
Yes, because I don't know that.
I think it's a hard question too. I think most of us are not going to be able to give a number, okay?
Yeah, okay.
They're going to ask us some questions like this in the exam because they want to stress us out. They know we're not going to know the answer. But at the same time, we should be able to characterize the relative incidence. So twins would be increased or has been increasing, and it would be more of a concern than higher order multiples. The most recent numbers that I have on this, and I just had looked at them the other day, were approximately 34 twins per 1,000 live births from an ACOG publication in the past, and about 1 higher order multiple per 1,000 live births. So a much, much lower incidence of triplets and above than twins. And I think that really kind of represents what you were saying, that higher order multiples are much less common, especially with the advancements that we've made in ART, right?
Yeah. Mm-hmm.
Okay, good. Let's go to the next slide.
Okay.
same question, 36-year-old treatment of primary infertility. The question underneath of it is, what primary prevention strategies can limit the number of multifetal pregnancies that result from the use of assisted reproductive technology?
So in the setting of IVF, transitioning more so to single embryo transfers can help reduce the risk of multifetal gestations. Additionally, in the setting of ovulation induction medication, using the lowest dose of ovulation induction therapy can help reduce the risk of higher order multiples, but the risk of twinning is between 5 to 8%.
Okay, good. So this question really kind of brings us full circle back to the original question about selective reduction and multifetal pregnancy reduction, which is kind of a secondary thing. But what can we do primarily? What can we do from the outset to try to reduce the need to get to that point? And you talked about single embryo transfer for IVF. Absolutely. The lower the number of embryos we transfer during IVF, the lower the risk for a multifetal pregnancy. Of course, it's never going to get to zero, because you can have twinning of an embryo that was transferred, or splitting of an embryo that was transferred for IVF. Mm-hmm. You talked about ovulation induction. Very nice, because you didn't just focus on IVF. And so with ovulation induction, in addition to what you were saying about using the lowest dose that's required, also if you are monitoring a patient during ovulation induction and you have suspicions for a multiple ovulation event, then you could always cancel that cycle if you are monitoring a patient. So that's another thing to think about. And then the last thing is kind of really not as much of an issue, but I think ACOG still mentions it in a couple of places. Using IVF instead of gonadotropins. I think we've kind of let gonadotropins go. I think it's really, we're not doing that anymore. But injectable gonadotropins, of course, are much harder to really control and are much higher risk for multifetal pregnancy. All right. Okay. That's the last slide. Do you have any questions for me before I let you out of the hot seat?
So back to the incidence question, was that okay to answer generally that, you know, the twins is higher, but would suspect the higher order would be lower, and just kind of leave it general?
I think if you don't have an idea of the numbers or the range of the numbers, then I think your best bet is to try to characterize it in general terms. So I would say this: if I didn't know the incidence, I might say, well, I would still, I'm not completely sure of the numbers, but I would anticipate that twin pregnancies are still a minority of the pregnancies, although those numbers have increased, and that higher order multiple gestations are going to be relatively rare. And I think 34 out of 1,000 is a pretty small number for twins, but it's still significant. And 1 in 1,000 is very low. So again, I would do what you did. You sort of tried to generally characterize it with what you knew, and I think that is the right answer. It's obvious that you know that twins is the most significant risk and that higher order multiples are lower from the answers that you gave. And I think that's really the key here, is get whatever credit you can by indicating to the examiners that you understand the underlying concept. Does that make sense?
Yeah, no, that definitely does.
I think exact numbers are not a pass-fail kind of thing, but if the underlying concept is not clear, if they feel like, man, they have no clue, then that's where you're going to be just having potentially significant points deducted from your performance. Okay?
Okay, yeah, thank you.
And by the way, I want to just mention, we all go into this exam thinking that the bar that we have to cross is perfect, that everything we don't know, that every wrong answer is going to do us in. That's just not true. If that were the case, many of us, maybe me, wouldn't have passed. Okay, it's really about being average, not about being perfect. But where you have to be perfect is in the high risk emergency type of scenarios. if you don't manage postpartum hemorrhage within the normal parameters, then how can you possibly be doing obstetrics? If you can't recognize risk factors for a major intraoperative complication or know how to handle a complication when it occurs, how can you be a gynecologic surgeon? So I think those emergency issues warrant a little bit of extra time and effort. When I say time and effort, I mean as you're getting ready for the exam, verbally presenting them so you can do it succinctly and thoroughly. And then I think for concepts related to the general practice of OBGYN, there's a little more room for having the concept, but maybe not having the exact numbers. Does that make sense?
Yeah, that makes sense. Mm-hmm.
Sorry for the mini lecture. I'm going to move on, okay?
Perfect. Thank you.
You're welcome. Let me get back to my list and we will get our next person into the hot seat. Dr. Sears, can I come to you next?
Yes.
All right. The next question. When should the estimated due date be determined?
Ideally, the estimated due date should be determined in the first trimester.
Excellent. Okay, let's go to the next slide. The earlier, the better. Okay, a patient presents for confirmation of pregnancy. What is the most accurate method to establish or confirm gestational age? Why is an accurate estimated due date important in prenatal care? How accurate is measurement of the crown rump length in the first trimester? And describe to me how you measure the crown rump length.
Okay, so the most accurate method for establishing gestational age would be an ultrasound in the first trimester that is consistent with the last menstrual period. So within 5 days, if you're under 9 weeks, and I believe 7 days up to 14 weeks.
Okay, keep going. I'll come back and I'll give you feedback.
Okay, I probably shouldn't have even said it, should I?
No. You answered two questions in one. You answered the first question and the third question with that answer. So keep going.
I see. Okay. Then.
So why isn't an accurate EDD important in prenatal care?
Okay, so an accurate EDD is important because I base a lot of my decisions and management off of the estimated due date. For example, timing of certain tests during pregnancy, such as genetic screening, potential diagnostic genetic testing, as well as your 24 to 28 week labs, including glucola, the administration of immunizations such as RhoGAM, as well as delivery planning and antenatal fetal surveillance, which all depend on an estimated due date.
All right, so tell me the answer to the fourth question. How do you measure the crown rump length?
A crown rump length should be measured using taking three measurements from ideally in the mid-sagittal plane, where you're able to see the fetal spine. You take a measurement from the top of the head down to the rump. I need to figure out what word I need to use. And then you take the average of those three measurements.
I like it. So I'm gonna go in reverse order. I'm gonna just reconfirm for everybody listening. According to ACOG, and you were really pretty much right in line with them, the crown rump length is the mean of three discrete measurements, the three separate measurements in the true mid-sagittal plane, which would have the genital tubercle and fetal spine longitudinally in view. And you take the maximum length from the cranium to the caudal rump, measured as a straight line. So I think you pretty much nailed that, okay? There were maybe
Okay.
one or two words that weren't in there, but I think what you said was basically exactly what I just said, which is what ACOG says.
Okay.
Now, going to why is an accurate EDD important in prenatal care? One thing that sometimes people ask me is, is this really an important issue? Absolutely. How to determine gestational dating is critically important. And you gave a lot of the reasons why, and I'm just going to kind of repeat this. So much of our appropriate obstetric care is based upon doing it at the right time, whether we're talking about testing, whether we're talking about interventions. And so, for instance, scheduling and interpreting antepartum testing. You mentioned testing for gestational diabetes. You mentioned giving ROGAM. I completely agree with those things. What about serial ultrasounds for fetal growth? If we do an ultrasound and we look at the size of the fetus and we have the dates wrong, the size is not going to be appropriate for what we're expecting. Interventions with a concern over preterm delivery. We make decisions about different interventions, whether we're talking about magnesium for fetal neuroprotection, latency antibiotics in the setting of PPROM. If we're talking about giving potentially corticosteroids for fetal lung maturity, all these things have gestational ages associated with the decision-making process. And again, the more accurate our estimated due date is, the better we'll be at doing these things. Preventing post-term births, again, related to the gestational age. So you cannot underestimate the importance of it. And with that in mind, the best measurement, or the best method, to establish or confirm gestational age is, just like you said, ultrasound measurement of the embryo, not the gestational sac, but the embryo in the first trimester. And I think you said that, and especially when that measurement is consistent with the menstrual dating, that really gives us confidence that we have a good dating criteria. We would use ultrasound plus or minus 5 days prior to 9 weeks, and plus or minus 7 days prior to 14 weeks. So up to 13 weeks and 6 days.
Okay.
I think it is important. I think we've mentioned this in other webinars, and I know we've mentioned it in our courses, that you should have a pretty good grasp of the accuracy of ultrasound at different gestational ages. So, when would you go to plus or minus 10 days? When would you go to plus or minus 14 days? When would you go to plus or minus 21 days? And that's generally around 16 weeks, 22 weeks, and 28 weeks. So you should be comfortable with those different cutoffs. Okay?
Yep, definitely need to review that.
Well, I thought you did pretty well, actually. If that's completely off the cuff, I thought that was very nice. Do you have any questions for me before I let you out of the hot seat?
I don't think so. The only reason I knew the crown rumpling stuff is because as a hospitalist, I don't do that every day. So I had just recently read that one.
Well, I'm really glad you did, because, I want to say something. So for many of us today, we are not doing our own ultrasounds. And what that means is that we're just getting reports. We're often signing off on those reports. But because we're not using the probe, we're not making the measurements with the calipers on the image, we sometimes, it's just human nature, we forget. It's kind of like airline pilots. Since so much is happening on autopilot, even though they really do know the background, they're not always clued into the details. And so I think the examiners care about, particularly with ultrasound measurements in pregnancy, that we have a pretty good grasp. I'm glad you had looked at that, because you obviously retained it. So nice job.
So, sorry, quick question. Regarding, do you think that is also true in terms of, biometry and things like, I guess?
Yeah, let me give you a couple of examples. I think that you should know that at 14 weeks that you're not going to measure the crown rump length anymore. Instead, you're going to measure the abdominal circumference, head circumference, biparietal diameter, and femur length. Okay? So I think that would be important to know. I think you could be asked a situation where a patient presents where the mother is in a code situation and is noted to be pregnant, and you have to do a very quick assessment to determine whether or not to intervene for the fetus during the code. And I would generally think about doing a femur length measurement in that setting.
Got it. Okay.
So I think these are things that you do have to be familiar with. And then of course we get to the abnormals. So the abdominal circumference has some special significance when we think about fetal growth restriction, for instance. And I think the more you know about that, the better. But that's, again, we're now starting to get into increasingly levels of detail that are maybe not quite as critical, but still valuable if you know them. Okay?
Okay, great. Thank you so much.
Yeah, thank you. All right, I'm going to get our next person into the hot seat. Dr. Mufaraj, can I come to you next?
Hi, yes, I'm on call, so I might have to go.
Okay, so if I give you a really hard question, then get a page and you can skip out, okay?
Okay.
All right, so here is the next question. If you hear some noise in the background, there's a thunderstorm going on where I'm at. So hopefully you guys won't notice it. Okay, so here's the deal. What is the chance that a woman in the United States will give birth via cesarean delivery? And what are the most common indications, should have an S on that, indications for, well, what is the most common indication for primary cesarean delivery? But I'd really like you to tell me the most common, the top three.
Okay, so for the first question, what is the chance a woman in the United States will give birth via cesarean? I don't know if that equates to what the incidence is of cesarean births in the United States. So that's 30%. And what is the most common indication or indication? So the first one would be fetal malpresentation. The second would be multifetal gestations. And the third would probably be placental abnormalities. So either accreta, procreta, or previa, or vasoprevia.
Okay, so first, I love the answer to the first question, 30% or 1 in 3 for cesarean delivery, likelihood of cesarean delivery. Excellent. Now, when we talk about indications for primary cesarean delivery, so have you done any cesarean sections recently?
No, I'm a GYN oncology fellow.
Oh, okay. Well, that makes this harder. I was going to tell you, when you get a question like that, always in the exam, stop it for a second. I'm talking for everybody listening tonight. Always think, what are the reasons I've recently done this for? And most likely, some of those reasons are going to make the top list. I would bet that if I'm going to ask you about placenta accreta. I bet if you think about that, maybe as a GYN oncologist, it might be the most recent one you've done. But for most generalists, probably not going to happen that often. So with that in mind,
my answers. No,
yeah, you want to give me new answers?
I think I would still say fetal malpresentations in the top, but then I would
probably, in the top 3, but it's not number 1. But I like it.
I guess non-reassuring fetal heart tracings would be also in the top 3.
Yeah, that's number 2. So what's number 1?
I guess abnormal progression of labor.
That's it. You nailed it. Arrestive labor. Okay. So when we look at arrestive labor, that's about 34%. We look at non-reassuring fetal heart rate tracings, around 23%. Malpresentations, 17%. These numbers I'm giving you are from ACOG's consensus statement on preventing the first cesarean delivery. So again, arrestive labor about a third, non-reassuring fetal heart rate tracing is about a quarter, and malpresentation is about a fifth. So when you put these 3 together, they represent the majority. Interestingly, most of the other things fall down into single digits. Maternal request, 1 to 3%. Okay, and when we look at, like for instance, placenta accreta, it's going to be a pretty small percentage. However, it is an important consideration that is becoming more common as the number of cesarean deliveries increases. And so let's go to the next slide. You're seeing a patient for her new OB visit. She requests a C-section. New OB, and she says, I really want to have a C-section. How would you handle this? And if you will, describe to me how you would discuss the risk of a cesarean section versus a vaginal delivery with a patient.
Sure. So, of course, at this stage, when we're discussing her requests in terms of her labor planning, I would have already obtained a thorough history and understood her obstetrical history, her medical surgical history. And then when she would come with that request, I would first, I would keep my questions very open-ended and non-judgmental in the beginning. And I would ask her, why she does request this particular method of delivery. And I would tell her that, per our guidelines, per ACOG, we do completely accept performing cesarean sections per maternal request. They are safe. And, I have personally done them in residency. And then I would try to, kind of elicit the reasons for this request. Did she have prior traumatizing birthing histories? Did she have prior surgeries and had troublesome postoperative courses? And so just try to understand that a little bit more. And then I would tell her that as her physician, it is my job to counsel her on the risks and benefits of a cesarean delivery versus a vaginal delivery and a possible operative vaginal delivery. So what I would start by saying is, both cesarean deliveries and vaginal deliveries are safe. Now, cesarean deliveries do pose a higher risk of complications given their surgical nature, mainly the risk of bleeding, the risk of damage to surrounding structures, the risk of infection, the risk of prolonged hospitalization secondary to pain or infection, the higher risk of VTE, and the longer recovery period. And then when talking about vaginal delivery, I will talk to her about the risks associated with lacerations, and I will quote that the most common laceration is a second degree. And then, of course, make sure that she is not at high risk for higher order lacerations. And then I will also, of course, talk about the benefits of both. The shorter recovery period of a vaginal delivery, the improvement or the IgA uptake of the fetus through a vaginal delivery, less pain post delivery, less risk of hemorrhage and infection, and so forth.
I thought that was a really wonderful, very thorough discussion. I want to ask you one more question on this issue. So if a patient has no maternal or fetal indication for cesarean delivery, and she asks for your recommendation, should she attempt a vaginal delivery or should she have a cesarean delivery? What would you recommend?
So I think before I answer that question, I will always try to ask the patient what their reservation is and actually answer their reservations rather than give my input first. So I can, I do actually have a patient from residency who did have big concerns about sexual health after a vaginal delivery and wanting a cesarean delivery in order to preserve her sexual function. So I can address those specific concerns. Now, let's say the patient does not have specific reservations or concerns, but she's just asking for my opinion. I would point more towards, or recommend rather, a vaginal delivery, given the overall healthier or less risky procedure associated with a vaginal delivery. But of course, I will remind the patient that, labor can be unpredictable. And if we do have to move to an emergent C-section from a vaginal delivery, there are higher risks associated with that than going to a scheduled cesarean delivery.
Okay. I love everything you said. And I can tell that you're very thorough. And I would definitely, I'm already have the impression I would send family members to you, okay? So I really like that. But I want to make a really exam relevant point here.
Mm-hmm.
If you're asked in the exam what you would recommend to a patient, so they set you up that the patient has no issues that would direct you to one way or another, and they ask for, in this case, it's a cesarean section versus vaginal delivery, but it could be external cephalic version versus a cesarean delivery, or it could be vaginal hysterectomy versus robotic hysterectomy. So if they ask you if the patient asks for your recommendation, would you recommend it? You really do have to be able to give an opinion.
Okay.
Now, I like the way you started though. You would first try to understand the patient's concerns and issues, and that is very, very important. But at the end of the day, when they ask for a recommendation, there are trade-offs and there are generally accepted best practices, and the examiners would find it strange if everything, even the most obvious best choice, is I never tell a patient any recommendation. I always just let them choose. Okay.
Mhm.
I mean, yeah, shared decision making, but they're coming to you for expertise. And we don't want to be paternalistic, but we also don't want to be so non-committal that we weren't able to give a patient good professional advice. So I thought you did a great job. I thought you did not leave me in doubt. Okay, but you also were thoughtful and thorough. And so I think that's really fantastic. I just want to go back and mention one thing about the first question here. How would you handle this request? You did this, and I want to highlight it. You talked about reviewing the patient's history. Sometimes you may get a question like this, and maybe the patient presented requesting a C-section because her previous doctor told her you have to make sure they do a C-section because of the uterine rupture you had with your last delivery, okay? Or because of the classical cesarean section you had at 24 weeks, or because of the full thickness myomectomy that you had. So again, I think a nice way to start with a question like this is to talk about, like you did, reviewing the patient's medical and surgical and obstetric history, because perhaps there is an indication behind her request. And if that's the case, you would absolutely endorse it based upon the medical indication and encourage, begin the planning process so the patient can be ready. I thought you did a good job discussing the risks and benefits, and so I'm not going to repeat any of that. I will just say one last thing. In the exam, if you're talking about a elective cesarean section, it's nice, even though it's obvious, to mention that you would never consider doing that prior to 39 weeks.
Mm-hmm.
And I think it's also nice to mention you would discuss with the patient their family planning desires, because if they desire a larger family, then potentially the risks of elective primary cesarean delivery may be more significant. Okay?
Yes, that's very important.
And with that in mind, there's one more slide.
Mm-hmm.
Patient with placenta previa has a history of 3 previous cesarean deliveries. What is her risk of a placenta accreta?
Yes. So 3 prior cesareans. I always forget this. Is it 4%? No, I really don't remember.
It's going to be higher than that. But so here's the thing. If you don't have the exact numbers, then you can always discuss the topic. What would you say about this topic?
Sorry, I didn't realize that she has a placenta previa. Yes, and
Yes.
3, so it's 40%.
So I would say the risk with a placenta previa and 1 prior cesarean would be, according to ACOG, approximately 11%. 2 prior cesareans, 40%. 3 prior cesareans, 61%. And 4 prior cesareans, 67%.
Okay.
This was from a previous ACOG publication. Now, I did not double check this today, so whether these numbers have been updated or not. But here's the key point. I think we can agree that if you have a previa and previous cesarean deliveries, that the number of cesarean deliveries, as they increase, the risk for accreta significantly increases. Would you agree with that?
Yes.
So this is where, again, in the exam, I might not have these numbers on the tip of my tongue, but I would definitely tell the examiner, this would concern me because with a previa and previous cesarean deliveries, each successive cesarean increases the risk for an accreta. And if I said that, that's completely true, even if I don't know the exact number.
Okay.
Sound good?
Yes.
Now, on the other hand, if you said, well, I would tell her that her risk is basically baseline. What planet are you from? That makes no sense, okay? So again, I know people are always like, well, are really going to accept that? Now, remember in the exam, no matter what you say, even if you give 61%, which is the number that I quoted, they're still going to look at you in many cases like you said something wrong, okay? So do not look to the examiners for reassurance, all right?
Okay. I'm
Okay.
a bit confused.
Yeah, go ahead.
Sorry, I think that we had, the reason I said 40% is I think we had discussed it in a prior webinar that if it was a history of previa alone without a C-section, the risk for necrete is 3%. If you add one C-section to the previa, it's also 3%, but then if you go to 2, it's 11, and 3, it's 40, and then 4, it's 60, and 5 is 67. I think we've probably discussed this many times, but those are the numbers that I've written down.
So here's what I'll do. First of all, definitely statistics are always risky because over time more data is collected. I can tell you that the numbers that I quoted you, which would be risk of accreta when somebody has a previa with a history of 1 prior cesarean, I said 11%, 2 prior cesareans, 40%, 3 prior cesareans, 61%, 4 prior cesareans, 67%. While we were talking, I just looked at where I have references noted for where these had originally come from. And this was cited by the person who developed this question as coming from Committee Opinion 761 from ACOG in January 2019. Now, I don't know if that committee opinion is still current. So what I will do is before my next webinar, I will double check these numbers and I will make a note to just give you guys the most current numbers I can find that ACOG references. Because again, you don't have to be exact, but you do want to be in the ballpark. And this committee opinion was on cesarean delivery and maternal requests specifically, but I know there may be other publications that are relevant. So I'll double check it and I will get back to you guys on my next webinar, which should be before the exam. So for the first group, so I'll be able to give that to you. Other questions before I let you out of the hot seat?
No, I really appreciate it. I think it's just a similar question echoing the previous person who was on the hot seat. Is just if you don't recall the percentages, it's better to always comment on general trends and then rather than just guess the percentages.
Yes. Now, let me just say, guessing versus having a gut feeling are two different things. Right. So if you have a general idea, like the first question in this case was what percentage of patients are going to deliver via cesarean delivery? And it was about a third, right? Okay. So if you have a general idea, your gut feeling about it, go with it. But if we're talking about a specific percentage and you really have no idea, then discuss the underlying concepts and demonstrate your knowledge of those concepts. And then you can mention, I don't know the exact percentage. That I would have to look up. I think in the exam, something that we lose sight of is not knowing the exact number is not as important as not knowing the concepts that underpin the data. Just like people will say, if I can't remember the name of a particular procedure, like Pinard's maneuver for delivering the legs in a breech delivery, is that going to be a big deal? I'll tell you, I'd rather have you describe the maneuver and tell me you can't remember the name than tell me the name and not be able to describe the maneuver. Does that make sense?
Yes.
And that's really how statistics are too. If you can describe the concept and give a general appreciation, you're going to be better off than if you can give me a specific number, but you don't really understand why it's relevant. Okay? If you get both, if you can describe the concepts and give me a number that's pretty close to the accepted number, then I'm super happy. But I'd much prefer you understand the underpinnings and be able to describe those concepts than give me a number that's just memorized with no appreciation for why it matters. This really is somewhat of a subjective judgment by your examiners. And you want to make it easy for them by demonstrating a broad understanding of the knowledge base rather than a superficial knowledge of some specific numbers. Okay?
Yes, makes sense. Thank you.
Yeah, great job. I'm going to let you out of the hot seat. We're going to get another person up into the hot seat, and we're going to do another case. Give me just 1 second as I go back to my list. And I apologize, just one more second here. Dr. Brown, can I come to you next?
Yes, you may.
All right, let me advance our slides. Who should you discuss PrEP with?
So I would discuss PrEP with anybody that I screen for higher risk of sexually transmitted infections, as well as, yeah, those would be my first.
Okay, I want to read all of you something from ACOG. Based on the CDC's clinical guidance and supporting evidence of benefit, ACOG recommends that OBGYNs discuss PrEP with all sexually active adolescent and adult patients rather than providing this information to only those considered at substantial risk of HIV infection. Does that surprise you?
Yeah, that does surprise me.
Yeah, it surprises me too. It surprises me too, because it's basically saying we should talk about PrEP with everybody.
Yeah, we don't even screen everybody for chlamydia, but yeah.
Yeah. So I think as we work through this, I think you'll see that maybe that's how we interpret that really makes the difference. So let's work through a couple of slides here, and hopefully I haven't got you on the ropes here. You seem like you were pretty capable when you answered that first question. So here's this next slide. A patient presents for her well woman visit. As part of that, you take a comprehensive medical history. Describe to me how you take a sexual history.
Sure. So I usually try to keep this pretty open-ended, and of course in a non-judgmental way. I just first start with the basics that this is information that I ask all my patients on their annual visits. I ask them both about their prior sexual history, number of prior partners, as well as their current partners. I also ask them about their sexual orientation at that visit as well. And I also do detailed questions about their sexual orientation as well as their preferred pronouns, just to make sure they're in a comfortable space.
Okay, so you talked about partners, you talked about sexual orientation, preferred pronouns. Anything else that you would try to elicit in a sexual history?
Sure. So like what type of sexual encounters that they experience, whether that be intercourse versus just oral, or anal sex as well.
Okay, anything else?
Number of partners, and then if they have any history of sexual assault or sexual violence.
Okay, now I'm going to make a couple of comments. You started your discussion with something that Dr. Mafaraj said in the previous case, open-ended, non-judgmental. I like that. I think that is really, really important. We have to talk about sensitive issues with people, and I think it's good in every discussion to be open-ended and non-judgmental. We have to really we're here for the patient. We're not trying to impose on them. We're trying to help them. And so I like the fact that you mentioned that. And particularly when we get into this kind of a discussion, some of the things that you were mentioning there, they're always, somewhat uncomfortable discussions in that you hate to pry, you hate to ask people questions that make them think that you're going to be judging them, even though you're not. Mm-hmm. And so I'm going to just mention one of the recommended ways to take a sexual history is to remember this idea of the 5 Ps. And you were kind of starting down that path. Partners, sexual practices, then protection from STIs. So what are they doing to try to protect themselves? Do they have any past history of sexually transmitted infections, and what are their pregnancy intentions. That's kind of the 5 Ps, and there are suggested open-ended, non-judgmental ways of questioning patients about these 5 P issues, if you will. And I thought you did a great job starting down this path. So for all of you listening, I think that sometimes a question like this could be a very difficult question in the oral board exam if you've never practiced it out loud. When we're doing it in context with a patient, it's a little bit easier than when we're being asked in an exam, how do you take a sexual history? In which case, some of us it'll be very easy, but for many of us it'll be a little bit more of a stressful question. So Dr. Brown, I'm going to continue to the next slide.
Mm-hmm.
So the top part is exactly the same. It's a patient for her well woman visit. As part of that, you take a comprehensive medical history. Describe how you would introduce a discussion of PrEP into your sexual history. And is there any evaluation recommended before initiating PrEP? And what antiviral medication is in the oral PrEP regimens?
Sure. So I would introduce the discussion of PrEP into my conversation with all sexually active patients that present to my clinic. I discussed that the purpose of the PrEP is to the administration of a medication to help prevent the transmission of HIV. So it's to be used for prevention. However, I would also recommend other things like condoms for the prevention of HIV, but this could be used in adjunct as well into that.
Okay, I want to stop you because I want to highlight it. You nailed it. The best way to introduce a discussion of PrEP into the sexual history is when you talk about protection from STIs and condoms and other methods. That's the opportunity to mention PrEP as a way, a strategy to prevent HIV in particular. I love it. Okay, keep going. Sorry.
Oh, no, that's great. Thank you for that. Any evaluation before initiating PrEP. So I would do a routine STI screening based on their age and risk factors before initiating PrEP, just to make sure they don't actively have any type of infections as well, including HIV. I would also just check their medical history as well. There are some medications that can be contraindicated with some of the antiretroviral medications, so doing a thorough evaluation for that. And then the antiviral medication, I always have to look up the exact medications in there, but I know Truvada, I believe, is a commonly used oral PrEP regimen, and it has a combination of different classes of antiretroviral medications in it.
Okay, good. So I'm going to just go back here for a second. Regarding evaluation prior to initiating PrEP, generally speaking, you want to definitely test for HIV before you initiate PrEP, because obviously PrEP is intended for somebody who does not already have HIV. You mentioned STI testing. I think that would be very reasonable, because if we're talking about initiating PrEP, now I want to differentiate something here. The discussion of who you mention it to is really what the very first question. I'm going to go back for a second, because I think this is important. I said at the beginning, the context makes a difference. So who should you discuss PrEP with? It's something we should probably, according to ACOG, mention to everybody. That's not the same as recommending it. And I think that's the key thing that helps me interpret this. They're just thinking of it as a prevention, something that could be people made aware of, but not necessarily recommended. Now, when we start talking about initiating it, generally when you look at this, there's going to be some risk factors involved. And so then testing for STIs would be appropriate. HIV in particular absolutely has to be done. Also, because of these medications and some of the potential side effects, you should check renal function, hepatitis B status, any history of bone disease, and lipids. These would be the recommendations before initiating PrEP. And then what antiviral medication is in the oral PrEP regimens? And I think this is a hard question that most of us are not going to know the answer to. So this is an example of how, as you go through a scenario, the questions get harder to something that a majority of us probably wouldn't know. Tenofovir, TNF, I think is the abbreviation used for it, is the common antiretroviral that's in the oral regimens. And again, they have combinations, but that's the one that's in all of the current oral PrEP regimens. And I think that is the end of this case. So Dr. Brown, very nicely handled. Questions for me before I let you out of the hot seat?
So for the discussion of PrEP, then it would be like patients with like a partner that's HIV, patients that engage like in anal sex. That's like when you would use that part of your conversation for more like recommendation versus offering.
Yeah, and actually, I'll tell
Okay.
you, there's a somewhat, in my opinion, complicated algorithm that ACOG has a practice advisory from 2022 that specifically talked about PrEP, and they have this CDC algorithm that talks about different questions, and as you work your way down, whether or not you would prescribe PrEP versus just discuss PrEP. And so basically, high risk things would include like an HIV positive partner who has a detectable viral load or an unknown viral load. Another high risk scenario within the algorithm, and the high risk scenarios, by the way, would lead to you recommending prescribing PrEP. So another high risk scenario would be that the patient has one or more sex partners of unknown HIV status, and that they don't always use condoms when they have intercourse. And then another high risk scenario would be the patient has had an STI, bacterial STI, in the past 6 months. And when you include also whether or not that is men having sex with men or women having sex with men, that can, and which infection it was, they, in this algorithm, they can kind of bring you down to higher risk or lower risk. So again, there's a number of high risk factors that would lead you to prescribe PrEP rather than just discuss it. Does that make sense?
Yep.
I think the absolute one you have to all know is if a patient has an HIV positive partner with either a detectable or unknown viral load, then we should mention prescribing PrEP to them. Because obviously, if they're HIV negative and their partner's HIV positive and they have a detectable viral load or unknown viral load, they're at increased risk for acquiring HIV from sexual activity. Okay?
Awesome. Thanks for reviewing that.
Yeah, nice job. And again, if you guys look at the practice advisory, there's a little algorithm. By the way, I don't expect anybody to memorize the algorithm, but you heard the way I kind of described it. I kind of picked out from the algorithm what are some of the high risk factors. Remembering one or two is good enough. Okay, now if you can remember all of them, awesome, fantastic. But I think for most of us, it's not going to be that easy. All right? All right, so Dr. Brown, I'm going to let you out of the hot seat. I am now going to answer questions. Oops, as I just took us, there we go. I'm now going to answer questions before we finish. So let me just work my way down. Dr. Binstead, did you have a question? Hold on, maybe I muted you. Let's see. Did you have a question? Try one more time. Dr. Binstead, do you have a question? I'm not sure why I can't hear you. I'm gonna move down the list and I'll come back and try again. Hopefully I can unmute other people. Let's see here. Dr. Harayadachi, did you have a question?
Oh no, it wasn't a question. It was just about the percentages of the placenta accreta and the placenta previa.
Yeah.
Yeah, I just had quoted it from the practice bulletin. So I think the candidate was correct because it says, okay, so this says for women with placenta previa, the risk of placenta accreta is 3%, 11%, 40%, 61%, 67% for the first, second, third, fourth, and fifth or more cesarean section, respectively.
Okay, hold on one second because I'm going to ask you to repeat that to me. Say it one more. Which practice bulletin are you quoting that from?
But the one that you mentioned may have been a more like a later publication.
So the committee opinion that I have quoted is 761, but I'm not actually did not look at this tonight before I came into this webinar, and it may or may not still be current. So that's why I was caring. Tell me the numbers that you said again.
Sure, this is the obstetric care consensus number 7, and it says it replaces committee opinion number 529 reaffirmed 2021.
Okay, so that obstetric consensus statement, I believe, is on placenta accreta spectrum. Is that right?
Yes.
Okay, so that would be a good reference. So give me the numbers one more time. If you have placenta previa with one previous cesarean, what did they say the risk is?
Yeah. So with one, it's 3%. Second
Okay.
is 11%. Third is 40%. Fourth is 61%. And then fifth is 67%.
You know what? When I look at these numbers, what I realize is that where we were, the numbers that were provided in this case are just missing the first one. And then if you slide it over, they all match up. So I'm going to go with what you said. I'm going to double check it, but I'm going to just repeat this for everybody listening. Placenta previa with one prior cesarean, risk of accreta 3%. Placenta previa with two prior cesareans, risk of accreta 11%. Placenta previa with three prior cesareans, risk of accreta 40%. Placenta accreta with four prior cesareans, risk of accreta 61%, and more than four, 67%. Does that sound consistent with what you were telling me?
Yeah, that's from
From the obstetric consensus statement on placenta accreta spectrum. Perfect. Thank you for clarifying that. I think that is a good resource. And again, it makes it easier that we clarified that right now. I really appreciate it. Okay, now I think we had some more questions. Dr. Foster, did you have a question? Let's see, Dr. Foster.
No, I don't have a question.
Okay, sorry about that.
Okay, no problem.
No, if you want to say something, go ahead, I'm here.
No, I don't have a question. I'm fine. Thank you.
Okay, all right, thank you. Dr. L1, did you have a question?
Yeah, I was actually going to comment on the same thing, but I think where we're getting confused is that the numbers that are quoted, the 3, 11, 40, 61, and 67, refer to that specific cesarean as opposed to a prior, like as opposed to a number of repeats. So the way that because I pulled up the original article to figure this out. But it's an
I like it. Okay, so tell me again, I'm listening.
So basically it says for women with a placenta previa, the risk of accreta is 3%, 11%, 40, 61, and 67 for the first, second, third, fourth, or fifth or more cesarean respectively. So it's saying that not for the first repeat, it's for their first cesarean.
Ah, so that's actually a key point. That actually maybe brings the numbers together now. If it's a primary cesarean, then we're saying 3%. Is that right? If they've never had a cesarean before?
Correct.
And then if they've had one before, it's 11%.
Correct.
Okay, so that actually explains the reference that I had because it was talking about history of, so it was starting with the second, the first repeat.
Exactly.
Yeah, okay, that's great. That's really, really helpful. So now I probably confused a bunch of people, but the key point here is if you're going to get into the nitty-gritty on the numbers, it depends on whether you're talking about a previa in a patient who has never had a cesarean, this is her first cesarean, versus a previa in a patient who had a history of one cesarean. That's where we were starting with different numbers. Mm-hmm. So Dr. Elwin, thank you very much.
Thanks.
And I actually want to say I really like the fact that we're having this discussion because it helps. You hate to go into the exam with confusion. And sometimes it's really just a small key point that makes the difference in the numbers. Dr. Schneider, did you have a question?
No, I agree with the last person who spoke. I was just referencing the SMFM obstetric care consensus. Thanks.
Awesome. Thank you very much. All right. Let me see here because I think we had a few other questions. Dr. Ume, did you have a question?
Oh, no, I was just going to say the same thing, too, that you were right.
I love it. Okay, this is great. I love it. Everybody.
How you using it. Yeah.
Awesome. Okay, Dr. Rivera, did you have a question? Dr. Rivera, did you have a question? Okay, not hearing anything there. I'm going to keep moving. Dr. Peng, did you have a question? I think I'm unmuting folks here. Let me see. Dr. Chisholm, did you have a question?
No, I didn't have a question. I just, what everyone else had talked about, I just copy and pasted what was from the OB care consensus number 7 into the text box.
Okay, great. Thank you very much. Dr. McDowell, question?
Oh, no, I was just helping support you in your original.
Okay.
Yeah.
Perfect. So that's great. I appreciate all the help there. Okay, so Dr. DiBella, did you have a question?
No, it was the same.
Okay. All right. Okay. Oh, sorry, I didn't mean to cut you off there. All right. So this is good. I'm glad we have nailed this one. Dr. Zoma, did you have a question?
Hi, I did have a question. I have a specific question about the PrEP. I actually have a patient on my clinic case list who has a partner. She's a pregnant patient who has a partner with HIV positive status with unknown viral load titers. She just doesn't know the viral load or count. So I mentioned in my case list, PrEP counseling. Is there anything specific in this particular situation for, just not, other than knowing like safe medications to give, because PrEP is safe in pregnancy and breastfeeding, but she just doesn't elect to know what her partner status is. What could I be asked regarding PrEP for this particular situation?
Okay, so since you have this on your case list, it brings it to a slightly higher level of expected knowledge. So for instance, I would definitely expect the pre-prescription evaluation, the things like we talked about, HIV testing, renal function, Hep B status. I would expect you to know that because you're potentially going to prescribe it. Okay. I would also expect you to know at least one PrEP regimen, and I would really be thinking about the oral regimens is what's going to usually be most commonly used, but I would know one PrEP regimen and how it is prescribed and administered. They're usually the oral regimens are once daily, but I would just know that, because if you've brought it up as something you might be prescribing, then you should be able to answer at least those basic questions, okay? The other thing is there's a few other kind of key concepts. Let me ask you a question and see how you would answer this. So is PrEP a long-term strategy?
PrEP would be considered a long-term strategy to avoid risk of encountering or receiving HIV through the partner, unless partners change or unless you do know the partner's status. But it should be considered a long-term strategy for safety for the patient or prevention for the patient.
Okay, and I just wanted to see, because my recollection, it's, yes, I agree with what you said, but the one thing that I would say is it's not a lifelong prevention strategy. Okay. So it's specific to certain situations and partner relationships, but it's not something, for instance, that somebody would do lifelong with all of their relationships as a way of preventing HIV. It's intended for individuals that can, during periods of increased risk, they could use this, but it would not be a lifelong, everyday kind of thing. Does that make sense?
Makes sense. This patient in particular, it's her husband. If she stays married with her husband, forever, but she wants to continue to protecting herself, that would be appropriate to say that this is something. Yeah,
I think that would be reasonable, and it would also it would be including other methods of prevention as well. PrEP is not alone. We talk about barrier methods and anything that the patient can do to lower her risk. Okay.
Okay. And one last question, because it is on my office case list, is there a chance that they could cross over and ask me OB questions regarding how to treat if she was, in labor, if the viral load was this count, or is there not much crossover from office to OB content?
So now you're talking about a different topic, which is if the patient herself is HIV positive, how would you manage her during pregnancy, right?
Or I guess so.
Because
yes.
because PrEP is
would
usually
be a
prescribed to the
different topic. You're
person who
right,
does
yeah.
not have HIV.
Correct. Yes, she does not, but
Yeah.
she does. Okay, you're right. Okay.
Right. So here's my answer to your question. I'm not anticipating in the office section that they're going to launch into a question and answer about HIV in pregnancy. I think that is a much more OB list or OB section of the exam type of question, a very high yield question in the OB section, but probably not as high yield in the office section. I would argue that PrEP is a much more office oriented type of question.
Okay.
So either if you have it on your list, or I would not be surprised at all to see a question about PrEP as a structured case for a quarter of all the people who take the exam. And I say it that way because they do shuffle the structured cases. So they're not going to give, everybody in 2023 the same topics. There will be some topics that repeat through most of the exam weeks, generally high yield emergency kind of cases. But I would not anticipate that PrEP would be something everybody will see. But I think I would be very surprised if some of you don't see it. Okay?
Okay. And you had all this information was from a practice bulletin. I believe I saw one recently, but it just wanted to check.
So some of the information I gave you was from the practice advisory, and other information was from non-ACOG sources. So for instance, I don't think ACOG, I'll have to double check. I don't know if they specifically have a publication that talks about the regimens themselves. I don't remember seeing that in the practice advisory. I think the practice advisory more focuses on who we should talk to about it, and then it goes into some of the CDC guidelines on who should prescribe. So, but yeah, definitely it is absolutely relevant. Okay.
Okay. Wonderful. Thank you so much, Dr. Foley. Appreciate it.
Yeah, you're welcome. All right. With that said, I am going to cut us off here. We're a few minutes after 10. I know we sometimes could go with questions forever and ever, but I think we've kind of hit on the majority of the questions that were raised tonight. I want to thank everybody for joining us. There will be another webinar tomorrow.